I am Dr. Nadim Haddad, the Chief of Gastroenterology at MedStar Georgetown University Hospital. I'm also the Executive Physician Director at MedStar Health GI Services. In our department, we care for a wide variety of patients with GI diseases, from pancreaticobiliary disorders to esophageal and inflammatory bowel diseases. We provide a comprehensive care approach, multidisciplinary approach to our patients with strong spirit of collaboration among our colleagues in other disciplines. I chose to go into gastroenterology for these couple of specific reasons, because it affords me the opportunity to not only to make diagnosis, but also to intervene and offer some treatment via endoscopy. I look at it as a hybrid between medicine and surgery. You're able to not only to diagnose, but also to intervene. And endoscopy allows us to do that and also to diagnose problems and also treat and save the patients major operations. I can tell you that the future looks very, very appealing and exciting based on what we have seen in the last 10 to 15 years. There has been so much growth in research and development in the field of endoscopy. So we're able to better diagnose, to more accurately diagnose conditions early on, before they turn into cancer. And this will allow us to intervene earlier and prevent cancer from development and avoid major interventions like surgery, chemotherapy, or so forth. The impact that we have on patients' lives is such a rewarding experience to see patients benefit from what we do. And the challenge of always trying to do better, the challenge of trying to improve our capabilities, whether in terms of the diagnosis, making the diagnosis earlier, making sure we have the newest technology to make a better, earlier diagnosis. At the same time, having the tools to intervene early and help the patients. And the fact that we're engaged in a lot of clinical research, leading edge clinical research, will provide our patients with the best care possible. The fact that the GI department has made a decision to create centers of excellence around specific diseases makes it unique. So we have established multiple centers of excellence within the department, one to focus on pancreaticobiliary diseases, one that focuses on inflammatory bowel diseases, another one around esophageal diseases, and liver diseases. So those are unique, and the fact that we have access to multidisciplinary approach to patient care also benefits our patients in order to provide a more comprehensive care in an efficient way, in an efficient setting like MedStar Georgetown. There are specific criteria. It's a long list of requirements, but the main ones are that you have to have the clinical expertise, and you have to have, in addition to just the clinical expertise, to have the research component that goes with it, and the other tools necessary to create those centers. And also maintaining quality, looking at your outcomes also. It's not enough to just call yourself a center of excellence, but you have to show results that you are living up to those expectations. It's probably best to walk you through a scenario, a clinical scenario. A patient is referred with a suspected pancreatic tumor. So the patient comes in, gets evaluated by our team in GI, undergoes an endoscopic ultrasound to make the diagnosis. And if we determine that it is cancer, then the multidisciplinary team is looped in. And the team includes a surgeon, radiologist that is dedicated to patients with pancreaticobiliary diseases, an oncologist, a radiation oncologist, a pathologist, and a team of fellows and residents that participate and learn. So the case is presented and shared, and then everybody weighs in, and we come up with a consensus recommendation. And then that recommendation is transmitted to the patients. Whether it's recommended to go to surgery, then they are scheduled to see a surgeon. So all this is expedited. So a lot of work goes behind the scenes that patients may not be aware of. They just see the end result. If the recommendation is to go a different path, go through oncology, radiation oncology, then they're scheduled to be seen by those specific specialists to start treatment. This is one of the unique centers of excellence. It's one of the it's the only one in the DC metro area, and the center consists of physicians, nurse practitioners, APCs, and the nurse specialist. And in addition to seeing patients, they carry on a multidisciplinary approach. They have a monthly conference where unique cases are presented, and the pathologists are pulled in, and radiologists are included in those, and the colorectal surgeons are included in these multidisciplinary discussions and conferences. So again, this translates into a more efficient way of coordinated care per se. So the patients are seen, whether they come through surgery or through GI. There's always that line of communication and coordinated care in terms of providing the best care to the patients. This is a center that I've been involved with, and this is sort of an area of my expertise and interest. So there's a strong collaboration between us and the surgeons, and we coordinate the evaluation, the diagnostic workup, and therapeutic interventions, and any other recommendation for our patients. So the patients are evaluated by us, surgeons, oncologists, pathologists are involved, radiologists who are dedicated to seeing these types of patients. And we focus on keeping track of our outcomes. Is this technique benefiting our patients? Are we having good outcomes, good results? Should we do something different? Is there something? We're always looking at the literature. Is there something new in the literature? Is there something new that we need to adopt? Do we need to change our approach, our practice? At the same time, we are involved in clinical trials that we, as a group, as a multidisciplinary group, feel we need to be involved in. We have a strong interest in GI cancer as a result of having Lombardi Cancer Center based at MedStar Georgetown, and with our interest in GI and GI cancer, And there's a strong collaboration between the two. And as a matter of fact, we have a new faculty member, and her focus is GI cancer, looking at patients with hereditary genetic cancer, and that's Dr. Kent. And the whole theme is about how to manage those complex cases. Patients. It's not enough to just diagnose patients with cancer. We're looking at how to prevent it. Do we diagnose it early, or even diagnose it before it develops? So an example is there are families where patients have, each member has a type of cancer, and somebody with pancreatic cancer goes to see a pancreatic specialist. Another one with uterine cancer, they go see a gynecologist. So multiple members of the families have different cancers, but nobody is aware of the connection. So it takes somebody who's interested in GI cancer to connect that, and then shed some light about the fact that there is genetic predisposition in that family. So it's important to bring them in and make sure they have genetic evaluation and genetic screening. And it's important not just for those members that have cancer, but for the offsprings. When do you start screening? Do you screen early? Do you screen at the age of 20 or even earlier? So that's the importance of having somebody with a focused interest on GI cancer. The multidisciplinary approach is unique, but in addition to that, our motility lab is well established and has been in existence for a long time, and a lot of experience, 30 years worth of experience in looking at motility disorders, dysfunction of the esophagus, which can be challenging, trying to, chest pain, trying to differentiate chest pain from a GI source versus chest pain from a cardiac source. And sometimes it requires, cardiac evaluation first of all, and then, some advanced testing for the esophagus. And we're fortunate to have faculty members here who are interested in this disease, and we have the technology to support that. As of note, is that we recently acquired a tool called EndoFlip, which is the most sophisticated way of assessing the pressure in the esophagus, the motility of the esophagus, real time. You can get an assessment whether the esophagus is working well or not right away. You can use it when the surgeons are doing surgery. Is the surgery, did the surgeon achieve the goal or not? Should they adjust the surgery while they're still in the operating room? So these are just a few of the advantages. One of our main endoscopic technique is endoscopic ultrasound. And I happen to be one of the people that learned it early on, started about 20-some years ago. And MedStar Georgetown has been the premier in these types of techniques. So we adopted the technique early, and what it does is that it allows us to look not only inside the GI tract, but outside the GI tract, within the wall. So as an example, the pancreas is outside the stomach, and it's been difficult to get a closer look at the pancreas or get a biopsy of the pancreas. But with endoscopic ultrasound, that's relatively easy nowadays. You go with the endoscope inside the stomach and then obtain a biopsy. And over the years, we maintained that skill. The endoscopic ultrasound has many advantages, and one of the main ones is that it allows us to stage cancer in the esophagus, in the stomach, in the rectum, in the pancreas, in the biliary tree. And those are important information to have when a decision is being made how to treat a patient. It also, in the area of the pancreaticobiliary arena, it allows us to determine if a pancreatic lesion is benign versus malignant. If it's benign, no need to surgery, and sometimes no need to follow-up, which is a big relief to those patients. And if it's cancer, catch it early and act on it early. Also, in the recent years, we've been able to turn it into an interventional technique, not just diagnostic. We can do so much with this technology, managing patients with pancreatitis. Instead of going to surgery for debridement, for resection, this can be done via endoscopic ultrasound. This is just one example, and there are many, many more. And one of the techniques, original techniques that we pioneered at MedStar Georgetown is working with our colleagues in CyberKnife in radiation oncology. We were able to develop a technique where we can plant the seeds which help the CyberKnife to direct the beam, the radiation beam, exactly where the tumor is. It's very rewarding, and really this is what keeps us engaged and going and looking to do better and better. And so many times we hear it from patients when they come to get treated at MedStar Georgetown. They feel the culture, they appreciate the culture, and they feel that they get a comprehensive care. They feel that we don't just treat the disease or the organ or fix a problem. Just we look at the patients as a whole. And also they feel the coordination between the different specialists, the different doctors and nurses within the organization. I want our patients to know that we have great doctors that care, great nursing staff, great nurse practitioners, we have great associates, great people, great specialists that speak to each other in order to provide the best care possible.